Okay, good morning, everyone. Thank you for joining us for the last Friday of November. This morning, we have a special ground rounds presented by Dr. Myrna Lichter and Dr. Carol Cohen from Sunnybrook Hospital on the care of the elderly and challenges that may present in their care, as well as looking after the marginalized populations that live in our cities and how we can help them. I know Dr. Lichter's done a lot of work in that area, so I'll have her start off the rounds and introduce Dr. Cohen for us.
Well, thank you all for coming today to our first Public Health Global Health Rounds at the department. Hopefully it'll be an annual event. I'm very privileged today to have Dr. Carol Cohen as our visiting professor. She is a geriatric psychiatrist, a professor in the Department of Psychiatry at Sunnybrook Hospital. And she's clinical director. She crossed out a bunch of stuff because she was modest. Clinical director of community psychiatric services for the elderly at Sunnybrook. And her interprofessional team provides assessment and management of older adults with mental health and substance use problems, including dementia, in their place of residence. That's homes, retirement homes, and long-term care homes. She's been very active in interagency, collaborative care, and planning in North Toronto. Along with planning related to behavioral supports, Ontario locally and provincially since the inception. And she teaches at the University of Toronto. She's very popular here at the medical school and supervises psychiatry residents during their geriatric rotation. So the reason that I invited Carol today is because I've started a new initiative on eye care for seniors, late life homelessness. Now we encountered geriatrics is like our subspecialty, how many patients we deal with. But late life homelessness came home to me in a very broad way. Because mostly inspired by the project that we had done on Out of the Cold. And in Out of the Cold, like we did some evening, we went to Out of the Cold shelters, we did eye exams and provided them with glasses and eye care as needed. But the last clinic we held, instead of holding it in the evening, we held it in the morning or noon. So these were people who slept over at the Out of the Cold, which meant these are people living rough. These are people who are not in the shelter system. And so I just wanted, and almost half of the people I saw at that time were over 50, including these two cases that I just present to you. The first one was a 76-year-old fellow. I hid his name. He had some mental health issues. Winston was 76 years old, living on the street. You would have identified him probably with the number of bags he carried as someone who was homeless. Winston was very intelligent. And when I saw him, I diagnosed him with glaucoma. He actually followed up in my clinic for the first time, and he was put on drops, which he was, I think, barely compliant with, but then he's been lost to focus. Winston has some mental health issues, but he's extremely intelligent and easy to talk to and a little bit maybe paranoid. So, following him up has become a challenge. My second case that I saw at the same time was a 54-year-old man with 4th stage lung cancer. Came in, he was hectic. He had moderate cataracts, which I said, he's fairly ill, but I thought, well, maybe we should do his surgery more expediently. Because of his health concerns. But people said, well, he's got 4th stage cancer. He's only got moderate cataracts, you can probably live with them. I said to him, well, how are you managing? And he said, well, I sleep on the all-night bus. And then as soon as the subway opens, I sleep on the subway. So when you see people sleeping on the subway, please think of this man. And again, he's been left to follow up. My case 3 occurred during COVID. We had to set up some tents in Moss Park to do eye screening. And this man was brought to us by his caseworker with a white paint on 200 vision. And Dr. Sloanovic was my student at the time. We looked at him. His problem, cataracts. 2 years earlier, he was diagnosed with cataracts. I said, just watch him. Now this man is legally blind. Well, she made a few phone calls and he was operated within 2 weeks with vision returning to 20/25 along with his independence. And we did publish our 5 cataracts that we had seen in people in the homeless shelters, and there are problems that we encountered, and I think there are policy changes that have to be made for people who are elderly with comorbidities. Remember, the elderly are very vulnerable in the shelter system. Everybody's vulnerable. But I know that at Seton House, they had a separate ward for seniors to protect them from the general population. And our last visit to Seton House, we saw 3 people who've lost eyes while in the shelter. So trauma is a big problem. So what are the problems with late life homelessness that we're, well, the mental and emotional challenges include, they don't have a physical home. They have high levels of complex needs. They have decreased likelihood of sustainable income, physical and mental and emotional challenges, including mental illness and addiction. And then they cope with the stresses of aging, physical and cognitive. And I hope that Dr. Cohen will help us deal with some of the challenges of dealing with our geriatric population. I'll turn it over to Dr. Cohen then.
Morning. Thanks for being here in person, especially those who have an exam, i.e. all of you. So I'm a geriatric psychiatrist. I do outreach in North Toronto. I don't see many people who are unhoused, but my patients, people I deal with, have enough trouble following all the drop regimens and everything else that you want them to do. So I cannot imagine what it's like for people who are unhoused to have to follow all those regimens. So don't have any conflict of interests. And what I wanted to do today, to take this opportunity to give you a few reflections on dealing with older adults. I see many, you see many, and I thought I'd give you some tips. This may not relate completely to the unhoused, but some reflections from someone who's done this for a few years. So in terms of introduction, I wanted to really just start with who is an older adult. I've had this debate, this discussion for many years. Is it over 55? Because you get your little discount. Is it over 75? Many of the people I see in North Toronto have had their mental health problems for many years. And just because they're 62, 65, 67, it really doesn't change much if they're otherwise healthy. Or is it over 65, which is sort of the traditional definition? Many people who used to come to my office, I don't do much outpatient work now, mostly outreach, were horrified when they get to the door and it would say geriatric psychiatrist, even though they were 85, 95. To them, that was something they didn't want to think about in terms of being older. So challenge you to think about that. It makes a difference with respect to policy. It makes a difference in terms of who you see. The people that you're talking about are older adults at 45 if they're unhoused. They have many conditions that would make them very frail and vulnerable. And some people I see who are 85 are actually quite robust. So it will depend on the population and where you're meeting them in your clinic or on the street. As we all know, it's a huge wave of older individuals that are coming. Depends on where you are in the world in terms of populations. In some countries like Japan, they're way ahead of us in terms of percentage of population of older adults. And we're catching up with them as well. So the first thing I always start with respect to teaching about older adults, that if you've met one, you've met one. They're all so different. Heard about some individuals, you've all met people in your clinics. They all have unique backgrounds, unique stories. That's why I love geriatrics, because they have a wonderful life story that brought them to you. I know you don't have time because the clock's a ticking and you got to see them and push them through. But if you can find out one little thing about them, that's a hook for next time, so that you can have a conversation with them. That would often be nice for you and nice for them. But they're all very unique. They come to you with different backgrounds, different emotional states, different physical health problems. And there is definitely not one size fits all with respect to older adults. I hesitate in talking to you about problems in older adults because it's always, again, this sense of ageism that we're going to talk about the difficulties they face, the challenges they face, rather than the resilience that you're going to see in your practice in terms of people who are older adults who've gone through all kinds of challenges. and maybe don't have any mental health or physical health challenges other than the ones you're seeing them for. So just to make that statement up front, that not everybody over 65, 55, 85 has a myriad of the mental health problems that I'm going to talk about today. So I thought I'd give you a quick mental health primer. I know medical school was a ways away for some of you, and psychiatry was one of those rotations that you had to go through, and you did. So just to remind you in terms of some of the problems that you might encounter or that might be there. I hear about all of you in my practice. I think of all the subspecialties, yours is probably one that almost all of my patients visit. So I don't know you personally, but I've heard about many of you, and many of my patients visit a lot of you because they have eye problems affecting so many different parts. So I know about camping out in the waiting room, and I know about the return visits, and I know about the eye drops, and many of my patients are challenged. But my last home visit yesterday was someone who had a fabulous experience at the Kensington Clinic, had their cataract extracted 2 days ago, and was delighted. So everything's not so bad. So let's start with cognitive impairment and dementia. I just wanted to raise the fact again that not everyone over 65 has major neurocognitive disorder, dementia, Alzheimer's disease being the most common. But the biggest risk factor, one we haven't been able to deal with, is age. So the older the client you see in front of you, the older the patient you see in front of you, the more likely it is that they have cognitive impairment. Most people with cognitive impairment are very good at their social skills. So they're going to have a lovely time talking to you. It's a big outing to come to your office and wait in the waiting room and see you for the brief time they do. But that doesn't mean they don't have cognitive impairment, which is going to make it difficult for them to remember what you told them, to remember those regimens, those lovely complicated drop regimens, and for them to follow through on the instructions. So just think about that in terms of, again, balancing the fact that not everyone in front of you has cognitive impairment, but the older they are, the more likely that they might have some. In terms of this population, which is the one that you were hearing about, people with serious and persistent mental illness, you're going to see them in different places. You're probably going to be underrepresented in your regular clinics, obviously overrepresented in the shelter system on the street. There are many people like this who have lived with these illnesses since they were in their teens or 20s. That's one of the fascinating things about geriatric psychiatry is we meet people who've been suffering, challenged with, dealing with, coping with, sometimes well, sometimes not so well, with mental health challenges since their teens, and now they're 85. We see people who were perfectly well with respect to mental health until they got to later life and they developed problems in later life. And then we see people with both. So we people who have had serious and persistent mental illness all their life, and now they have higher risk of developing cognitive impairment and dementia. So we're going to see this interesting interplay. And as you alluded to the fact that some of the people you're seeing who have longstanding addictions, longstanding paranoia, may also now have cognitive impairment. So they've got a double jeopardy in terms of trying to deal with both of those things. In terms of the mental health system, it is a fragmented, challenging system. As fragmented as your system might feel, mental health system is very fragmented. It changes all the time. We're constantly stressed and striving to provide care to our patients longitudinally, but it's very challenging, very difficult. One of the biggest challenges is helping people transition to their systems. So people who are at home, who move to retirement homes, if they can afford it, because that's getting very pricey in Toronto, start saving now. Make a lot of younger friends now because you're going to leave them when you're older. And then trying to challenge to the long-term care system. As you may have heard, there are thousands and thousands and thousands of people on the waiting list for long-term care. It's very challenging to get there. That's a population that needs you very much so. Not just the retirement home population where they can often travel to you, but the long-term care home population that can't travel to you, many of whom have eye problems that are undiagnosed and untreated. So in terms of preventing dementia and thinking about that, this is the updated version from the Lancet Commission on Prevention of Dementia. We've done pretty abysmally on treating dementia, although I know there's those new fancy drugs that are coming by infusion where everybody needs follow-up MRIs every so often, and we're coming to that in Canada. That's where we are in the United States. But in the meantime, the news has been much, much better on this front with respect to preventing dementia. So delaying the onset of dementia. So there's things you can do in early life, which is get an education. You've covered that. There's things you can do in midlife, which you're not there yet, but talk to your parents with respect to things they can do to prevent the onset. One of the new things that's been added this year is vision loss in late life. Right? That's one of the first things that popped out to me was, wow, vision loss in late life might predisposition to developing dementia. So this is a really interesting graphic. They update it every couple of years. Some of the usual suspects are in there in terms of smoking, hypertension, obesity, alcohol. Hearing loss is another interesting one in terms of correcting hearing loss. So again, that's a really interesting infographic to think about in terms of delaying the onset and preventing dementia. Delirium, acute onset of confusional state. Again, you might not realize that or see that, but you might know someone quite well and all of a sudden see them and they're very, very different than their baseline. And maybe it's not because they developed Alzheimer's disease since you last saw them, but maybe there's an acute onset of a medical problem. Of course, in the hospital, any day that you walk into the hospital, you're going to see a huge percentage of people who are delirious, not all of them hyperactive delirium, such that they're running down the hall, tearing out their lines. There are many, many people with hypoactive delirium. I've met people who thought they were dead for 2 weeks. It's very distressing and difficult when you believe that because you're delirious. So my second to last home visit yesterday was someone who I was asked to see because of an acute mental status change. A little frustrating by the time I got there as the geriatric psychiatrist because they were on their second antibiotic for a UTI. And the palliative care team was already involved. So there was clearly medical stuff going on. And I said to the poor power of attorney that I don't think you need a geriatric psychiatrist. I think you're covered in this realm. And it's most likely a delirium because there's this acute change on November 1st from someone who had been one way and now all of a sudden they're very different. So think delirium. If you recognize it, please shout out and get someone to get some help because it is a very important and often very treatable. I'm hoping for this lady that she reverses back to her baseline after she's had the treatment for urinary tract infection. Depression, okay? Older adults do get depression, just like younger adults. It is very treatable, and it is actually less common in older adults. So many of you who meet people will think, no wonder they're depressed. Their life circumstances are difficult, challenging, etc. But in fact, major depression is less common in older adults. It might be more common in certain venues and in certain situations where people have chronic pain and chronic physical health problems, but it is not more common. So if you meet someone who's depressed, that doesn't mean they can't benefit from treatment, whether it's medication or psychotherapy. So it doesn't mean just because you get a certain age that you're going to get depressed and that's not true. Psychosis. So some of the people that you were talking about obviously have had a long-standing psychosis. You can get people with early onset psychosis. They develop their schizophrenia, their paranoid disorder early in life. And then my most interesting patients are the ones who didn't have it in early life, but have developed it in late life. So the ones that are well known to the mayor, premier, prime minister, because there's all kinds of stuff going on in their apartment. There's a grow up next door. There's gas being pumped in, et cetera, et cetera. No insight, not willing to take medications. Fine when they go out, but not so fine when they're in their apartment. So we can see psychosis in a range of situations. We can see it in delirium. We can see it in dementia. We have patients who are so depressed, they become psychotically depressed. I have no money. Can't stay in this hospital anymore. I'm running outside in the cold. I have no insides because there's nothing in there, doctor. So that becomes the medical emergency. And substance abuse. Obviously, people can have psychotic symptoms in the context of that. So we can see psychosis as well in late life. And sometimes it's a new onset and sometimes it's been there for a long time and has affected their quality of life, their ability to get married, to hold a job, etc. So substance use disorders, again, fascinating, early onset versus late onset. Unfortunately, there are some people in retirement who develop a substance use disorder, start drinking too much. misusing the opioids that their family doctors prescribe. And then we have the whole cannabis story, right? Everybody's kids who think that cannabis must be the best thing for their parent for anxiety, depression, sleep problems, pain, and they're all going to the cannabis clinic. And if I don't go to cannabis clinic, but if you do go, it sounds like it's an N of 1 study. So my poor patients who have a little cognitive impairment are being told, try this dose, and if it seems to work, then you can titrate it upwards or downwards, or take 1 or 2 or 3. And they're not quite sure what happens when you take an edible, so they take another one and another one. And so we are seeing older adults with intermittent substance use disorders, or ones that are lifelong. And again, treatable, diagnosable, and one that can be really helped. Other substances as well, if you're looking at the downtown crowd, again, depending on what you define older as, you got 55-year-olds who are on all kinds of substances, way beyond cannabis, opioids, prescribed, and alcohol. So there's lots of street drugs and things, and just because they're 55 doesn't mean they're not continuing in that culture. One of the most challenging parts of my practice now and in the whole system is that many of these people with earlier onset mental health problems, whether it be psychosis, depression, substance use disorder, personality disorders, are ending up in long-term care homes. So we've got people 55 who are creating mayhem in these situations because of physical health problems. They've been moved there, their physical health gets better, but now they're in a long-term care home. They don't like the rules too much. They don't want to play bingo, and they don't want to hang around. So during our complex case resolution rounds this week, we heard of a 63-year-old woman who was creating chaos in a Scarborough long-term care home because she was now physically better so she could get out on her scooter. But she was going out every hour of the day and not signing a little book you're supposed to sign when you go out, and not letting anyone search her bag when she came back to see whether she had any illicit substances that she might be trying to sell, et cetera. So this has become a really challenging issue with respect to long-term care. So as I mentioned, our system is fragmented, it's underfunded, challenged. There is a lack of affordable housing, not just for young folks, but for older adults. The long waiting list for long-term care. We have lost several long-term care homes in this city, and we're losing more because they don't want to renew their licenses. And they sell the land off to condo developers. So we have fewer long-term care home beds. And hospital admissions, unfortunately, for many of my patients, the answer is not to put them on a Form 1 out of the Mental Health Act, send them to the hospital and hope they never come back again, because they'll be back in the long-term care home or back in their home before the end of shift. And so it's a frustrating system for people trying to get access and help for individuals. So this is a cute video put together in terms of thinking of the 5 M's of geriatric care. Canadians were at the forefront of developing the 5 M's just to get you thinking quickly about what it is you should be thinking about for older adults. 2 students put this together. Medications. Are they doing good, harm? Their mind, how is their cognition? Their mobility, very important. Multi-complexity, as you know, your patients are complicated. They don't just have eye problems, they have many other problems. And I like the last one the best, which is what matters most. So what is most important to that individual in front of you? Advanced care planning, thinking about what matters for capable or incapable persons working with their families. So that's a really interesting mnemonic to think about. So I thought I'd end with some tips on communicating with older adults. And I apologize if these are too simple, but I thought it would be just interesting in terms of thinking about it. I talked to a lot of different groups. So I talked to police officers, financial advisors, lawyers. And so I often just think about in terms of tips of communicating with older adults. I know you have a small period of time with them, but what you say and how you say it matters very, very much. So it's really a matter of looking and listening. You guys are great listeners. You're good listeners and accommodating to them in terms of their challenges. Can they really hear you? You know they can't really see you. So what do you do about that and how do you accommodate for that? So these are some bedside manner tips that I pulled from the National Institute of Aging. I like to use proper forms of address. I'm always addressing people by Mr. and Mrs. I'm just old-fashioned about that. Unless someone really yells at me consistently about calling them by their first name, I don't. But again, it's a personal matter. Making people feel comfortable, just taking that extra little time to make sure they're comfortable in their surroundings so that they can hear you, accommodate to them. Taking a few minutes, I know it's going to be just a few, to establish some rapport with them. Trying not to rush, which I know is so impossible when you've got so many people waiting for you. That's really, really challenging. Avoiding interrupting. Again, they love telling you long stories. So it's really hard to figure out how much you let them talk. Sometimes by letting them talk just a little bit, you can see whether they can even put their thoughts together in a coherent fashion. So it may be worthwhile to give them at least a minute so you can hear their thought process. Because if their thought process is very jumbled, then you're going to know you're going to need to write the instructions down for somebody else. And using your active listening skills. So whatever you can use to listen in terms of what they're trying to tell you is really important. Writing down takeaway points. I always, if somebody's confused, having trouble, I'm going to write it down, hopefully legibly, hopefully in large print so they can read it. Demonstrating empathy, obviously. Avoiding jargon is really challenging, but our patients do not understand all our acronyms. Be careful about the language that you use. Keep it simple, not so simple that it's condescending, but simple enough they can understand. And try as best you can to ensure that they understand what it is you're trying to communicate to them in your short period of time with them. Hearing loss is huge. So most of your patients, even though they don't say it and aren't wearing hearing aids, probably can't hear you as well as they think they can. So think about that when you're talking to them. You don't have to shout, but you may have to speak a little louder and you may have to enunciate. And many of our patients are lip readers, whether you know it or not. So masks are a challenge. It's a nightmare. But if you're not masked, make sure they can see you. The light's not blinding them so they can't see your lips because they're probably lip reading and probably using that as a way. So that's why I use a lot of hand gestures. I slow down my speech and I exaggerate things so that sometimes people can hear me that way, even though they can't hear just by normal. You know all about this problem, but many families and people I deal with don't know about these problems. So they don't know that their clients can't see them. They don't know that it would be helpful to put the food on the edge of the plate if someone has macular, because they wonder why they're not eating their food that's at the center of the plate because they can't see it. So thinking about where you sit, and who can see you and how they can see you is something that you guys know better than all of us. In terms of setting the stage, you want to think about your offices, how they're set up, how your clinic is, the challenge of privacy. In the shelter system and in homes, it's often a big challenge just to get a time alone with somebody. And for me, when I'm coming in, even when I don't think I look like the doctor or with someone who doesn't look like the social worker, because I don't wear my badge and I just carry my knapsack. But sure enough, people in that apartment elevator know who I am, and they want to make sure I'm going to see Judith in 2B because she really needs to see somebody. So just going into a shelter, going into an apartment, seeing somebody, they all know that there's a professional. Thinking about how to reduce the stress of the visit. Our patients, my patients, are incredibly stressed by going to your offices. It's a big outing, it's a big deal. Sometimes they've had to get up early, they've had to do wheel plans, they've had to organize transportation. All kinds of things have gone on to getting them ready and dressed for your visit. And often they're dressed to the nines for your visit, just the way they are for the family doctor. Maybe the first time they've been dressed like that for months. And listening and time is important, and I know you don't have a lot of that. So try to think about distractions that might be on. When I go into home visits, I'm turning off the TV and the radio. If you can, sitting at eye levels so that really they can see you and they can read your lips, and slowing things down if you can. I'm a very fast talker, so I got to slow things way down when I go see people, and enunciating very clearly and simplifying your language. Again, not to be condescending, but to avoid the acronyms. Think about your body language and facial expressions. So use that to your advantage. That'll help you communicate. Be respectful and not condescending. If you can, I know you don't have a lot of time, But the open-ended question is going to give you an answer where you can listen to the thinking process and hear whether someone can put their thoughts together before you go into the very close-ended questions, which are yes, no, and then you don't have a chance to hear how they're thinking, how they're communicating. Humor is okay as long as they get it. Humor is great. And reality orientation is not always helpful. Those people who are trying to tell folks, no, that's not what happened. This is what happened. Doesn't really help. These are some resources for you in terms of places that you might go if you're really worried about an older adult. The Toronto Seniors Helpline gets you a trifecta of services. It gets you home and community, or Ontario Health at Home. They've only changed their name 15 times since I started that. It gets you community services such as Meals on Wheels, friendly visitor, day programs, etc. And it also gets you a crisis service. So there is a crisis service for older adults for mental health crises that's available through this line. It's not a 24-hour line, but I don't think you're going to be calling them at 2 in the morning. So if you're very worried about a senior in a mental health crisis, or you think they need other services, that's the number to call. If you're at all interested in anything related to mental health, older adults, for yourself, your family, your clients, these two websites are very helpful. The Canadian Coalition for Seniors Mental Health has all kinds of brochures for individuals, all kinds of interesting information and lots of stuff. If you're looking for an outreach team or somebody who's going to go visit them in their home for mental health problems, the group out of Baycrest in Toronto is the one that deals with sort of navigation. They have a huge navigation office, which is almost bigger than my outreach team. And they have a huge number of services that go into people's homes, retirement homes, long-term care homes. They do not just sort of mental health as in psychogeriatric like I do, but they have something called Behavioral Supports Ontario, which is people that go in and try to do with non-pharmacological intervention. And then the regional geriatric program is the counterpart to what I do. They're the geriatric medical folks. They run falls prevention programs, day hospitals, and geriatricians who are available through those kinds of services. So that's all I wanted to talk about this morning. I know you guys are getting ready for exam, but I'm happy to hear about your experiences, things that have worked in dealing with older clients, or challenges, or things that you wanted to elaborate on. It's gone very fast, but I've left lots of time for interaction. And I figured, lots of questions. Yeah, there's lots of questions. Well, we're gonna hold your questions. Anyone else got experiences, useful tips that they have found in running their busy clinics, dealing with your clients, your patients?
Collateral history, probably.
Yes,
Yeah.
thank you. Collateral history. Geriatrics is built on collateral history. So getting somebody else, if you can, if they're accompanied, not waiting in the waiting room, but coming in, thank you. I knew you'd have lots of tips. Collateral history is king in geriatrics. It's amazing how different the story is from another perspective. Sometimes you have to square the circle because sometimes that story is also got problems, but it's very, very helpful to get collateral history. Other tips that you guys have used? Any other pearls for your colleagues to share? Now you get to ask your
Oh,
question.
well, you know, I just had an incident with you this week where she had 4 phone calls about somebody's post-operative instructions.
Yeah.
And I wonder, you know, I sometimes wonder whether we should be addressing, you know, handing somebody a sheet that says, this is what you're going to do. And I get them in my office and say, but I know she got 4 phone calls, including 2 at 4 in the morning.
4 in the morning for post-operative instructions, yeah. Do you guys, is there any way you can set up, or you know whether someone's gonna need help beforehand, so you can set up nursing through Ontario Health at Home? I mean, I know it's hard, but for some clients, they will come and do drops, the RNs through that service. So if you have an inkling, I mean, I know when my patients go in for a hip replacement, the pre-op clinic goes through everything in a very detailed fashion in terms of trying to understand what they're going to need post-op. So it may be a nice project to figure out how you figure out which of your patients are going to need additional post-operative support such that they can actually do the drops or don't call you at 4 in the morning. I don't know how you ease that out because certainly I see people who I know are never going to be able to follow through, and I'm always making that preemptive arrangement to make sure they've got someone coming in, or that there are community services. As limited as they are, they're very limited, but it may be helpful to do that kind of preoperative screening to know who's going to need extra support.
I'm off service this year, but anytime I'm explaining like next steps or investigations, I get a family member, like usually a spouse or like a son or daughter on the phone, so that I explain to them, they're on speakerphone, and then they later discuss. Kind of.
So you make sure somebody else always knows. Yeah, no, I think that's unfortunately takes more time, but it's well worth your wait, because otherwise you're not going to get them following through on things.
Can I make a point?
Absolutely.
So one of the things I'm very fortunate in that when we examine patients, we have more than one lane. And I find a lot of times seniors will come with a family member, and you may present something to them and it'll take them a little bit of time to digest it. One of the things I found helpful in those circumstances is to say, look, I'm going to give you from a little bit of time. I see the next patient, and you give the patient 10, 15 minutes to discuss it and sort of like absorb it with their family person who's accompanying them. And then when you come back, they're usually in a better point to make that decision, I find. So not pushing the decision, because that'll often frustrate them. Just giving them a little bit more time, stepping out, it allows them to talk amongst themselves with the senior and their accompany person. And then when you come back, not always, but a lot of the times, they've had a chance to think about it. And if they haven't, sometimes I'll say, well, look, take it home, discuss it with your family, and get back to me with regarding what you would like to do.
That's brilliant. I like that, because again, time is of the essence in terms of giving people time. And if you can organize your service such that they can do that, that's great. Because otherwise you're going to get people changing your mind or not making a decision at all. And it's going to slow you down as well. So I like that a lot in terms of giving.
The other thing is, if you're pushing the decision, you can just watch them get more frustrated. So it's better, in my opinion, it's better to just give them that time. Usually just a little bit of downtime in the office without you being there is very helpful. And if it's not enough, then let them take the issue home.
You guys have infographics or other simple ways of explaining some of the things that you're asking them to make decisions about?
Yeah, I can make a comment on that. I think at Kensington, one of the things that I've received feedback from our patients is for the following cataract surgery, patients use a lot of drops. It can be up to 70 drops within the first week, right? 3 different bottles, but 70, the burden of drops is 70 in total, which is a lot. And what we've done is created a little calendar with check boxes, and every time you put a drop in, you check that box. You don't forget. Did I use my breakfast drop? Did I use my lunch drop? Did I not? Should I put another one in? Every time they do a drop, they cross it off, and they just follow that for the month. And that's been really appreciated. I was going to share one comment with respect to marginalized patients. There a number of our cataract patients, sometimes the worst cataracts are in patients who are marginalized, and that makes total sense because they lack access to care. And then there's the additional challenge that some of these folks don't have any close friends or family around who can support them, and yet we require them to have somebody with them on the day of surgery, and they're going to get canceled if they don't have somebody with you. And I've been in this unfortunate situation where people are aware that they need this, but it's never actually come up that they don't have anyone that they can bring with them. And so we have no choice. It's always unfortunate because these patients are the ones who typically need cataract surgery the most, and they end up getting canceled on the day of. But you can actually, CCAC has been helpful in terms of organizing a caregiver who can stay with the patient when they get home and overnight for the first day. So that's just my pearl there.
No, I totally agree. And that the problem is some of these people might be too embarrassed to tell you that they don't have somebody. And for some of my patients, it's a huge deal to organize someone to bring them and to mostly pick them up. Some of my patients can afford to hire someone, but on occasion, again, through that Toronto Seniors Helpline, you might be able to get a sympathetic person from Ontario Health at Home who would help you with that. But yes, rather than having it canceled. It's going to be hard to know always. Sometimes it's pretty easy to guess from what you're seeing that this person might be marginalized. At other times it's going to be more difficult. Yeah. Yeah. It's a huge challenge, and the system is so fragmented that sometimes it's hard to get that on.
Well, Dr. Cohen, that was going to be my question for you. This is just like everything else, you know, it sounds like the system is fragmented, whether it's, you know, the work that you do or just healthcare in general. Like there's so many challenges. What systems issues do you see that need to get addressed in order to make things better, right?
Again, for me, which we've been working on forever, and it's a slow process, which is connecting the dots. So figuring out how to work with the family doctor, the patient's family, whatever services are in their neighborhood, and figuring out how to put together a system that will work for that person. Because many of the people you're going to see who are very marginalized are actually well known to people in their community, just that you don't know how to find those people they know. So they're known to the superintendent in their Toronto Senior Community Housing Building. They're known to that community agency that you can find through. But again, you don't have time to call up and start figuring out who knows who, and that's part of the challenge. So how can we connect the dots so that when someone comes to you, those dots are connected and that information can be given to you as a specialist? So this person lives in this building, this is who's available. Marge down the hall could do the drops twice a day. Home and community can do the drops the other days. And the family doctors. I mean, again, your notes don't go anywhere. I can't see them on Connecting Ontario often. And so again, the old Connecting Ontario issues. So not that I can understand them when even I can access them because of all the acronyms and shorthands you use. But I don't know how often your offices can connect to a family doctor who might be very well aware of all those people in the background that are hidden from you, the people that know this client. So it might be helpful on occasion for your clinic or office to reach out to the family doctor, connect those dots, because between the specialist, the family doctor, and all the community partners, we need to connect that. It's happening slowly through Ontario Health Teams, but you folks are going to be way on the fringes of Ontario Health Teams, right? Ontario Health Teams are trying to connect all those people in different geographic regions of the province in Toronto. But how often does anyone here actually call a family doctor?
You know, Dr. Cohen, I can tell you that one of the challenges for us is most of our patients in ophthalmology, I would say the majority of our patients are coming to us not via their family doctor, but via their optometrist. And so it's true that the family doctors are often left out of the circle of care. If the patient gives the name of the family doctor at the front desk, they will get CC'd on the report back. But in theory, most of our letters are going back to their optometrist.
I have to tell you, we are establishing, it's already established a specific clinic for marginalized patients, a clinic at KEI, and it'll probably be held twice a month. But I'll probably communicate because this clinic, in order to be fully operational, has to have inclusion with community support.
Yeah.
And
so that you'll get to know, I mean, if you run a clinic like that and you get to know the community sector, they would be thrilled because they have many clients who they think need your services. So the more you get to know those folks and the more kinds of connections you make, the easier it'll be to replicate that and to move forward with that.
yeah, and so, yeah, the primary center we're working with right now is Canadian Center for Victims of Torture,
Yeah.
but they're very well supported. It's the other 50 shelters in Toronto that probably are not as well supported.
I mean, primary care I know is very separate from you folks because of that diathesis, it's optometrists and you. So how do you find out about people's other medical conditions? You're relying on them to tell you that?
Yeah.
For the most part. For the most part, yeah, because that puts you at a disadvantage in terms of not necessarily knowing all that information. Because you don't have the opportunity to do a deep Connecting Ontario dive in every client that comes into your office that won't work.
It'd be interesting to do a QI project on after we've discharged a patient who's had cataract surgery about what they understand about their surgery, what they've done, and whether they're actually compliant with what we've done.
Oh, absolutely. Yeah, because I've seen the good, the bad, and the ugly with respect to those drops in terms of how they're, So I love the fact that you've got these sheets because my patients would so benefit from that because most of them can't keep track of all the drops. Plus, you see them in follow-up and they need an extra drop, or you see them in follow-up and they need drops more often. It's just something they can't keep track.
I'm wondering, so is it possible to have a social worker kind of work for like our hospital ophthalmology
be great.
department? So like I know like a lot of internal medicine where they have a social worker in-house and then they can contact them if the patient need actual help. But like we don't really have a social worker in ophthalmology. And
I
then
mean, if you did a needs assessment, you would see whether you could make a case study for that. I mean, depending on the number of cancellations, the number of people who are having complications because they're not following through on their drops, et cetera, et cetera. We'd all like an extra social worker, yes. Yeah. So it's a matter of whether you could create a case for somebody who would do that in specific circumstances.
Comparing the costs of a social worker versus admission. Because that's what ends up happening.
They end up admitted.
Yeah.
That's right.
Yeah. How often do you see that?
It's like once every rotation, I think.
Once every rotation. And why do they end up admitted? How bad, what kind of,
Drops.
and then what kind of complication has happened?
Like usually infections,
Infection, because they haven't done those drops properly. Yeah.
where they can't do the drops, and so they get admitted.
And of those people, once a rotation who get admitted, are you surprised that that's the one? No, you sort of had an inkling that this person was gonna have trouble with that. Yeah. And
So it's, I think comparing the cost of having a social worker for that purpose versus admission, the cost of admission would be interesting.
again, I know it's challenging in that your model is very, very different. And the kinds of services you're providing and the kind of clinics you're running is just very different than other subspecialties because you've got such volumes and such. But, you know, the kinds of surgeries you do now, I've been around long enough. I was telling my patient yesterday that we practiced as medical students our histories and physicals on cataract patients because they came in the night before. You did your history and physical as a medical student to practice. And they had their surgery and then they were in hospital a day or two. So you saw them after that. So I've been around long enough to remember when it wasn't a quick visit to an outpatient clinic to get your cataract done. And so it's just changed dramatically. So we're gonna get a social worker in the wonderful world of wishes. Yeah. Any other last thoughts or last words of advice from you guys on screen?
No,
You
I
guys-
want to thank
Oh. Rose. You guys are getting ready to write a 4-hour exam, so they're very distracted and very anxious.
this is wonderful.
Thanks so much for listening and your ideas, and I look forward to hearing more about the challenges you face. Good luck on your exams. And my patients will all be talking about you as you graduate and go into practice because I hear all about you and your clinic. Thanks so much.
Okay, well, thank you. I think I got cut off there, but thank you, Dr. Cohen, Dr. Lichter, for your rounds this morning. Much appreciated.
Take care now.
You haven't.
Bye.
I think it's a great